on that point of the little a particle, the people that are listening that are on a statin right now are more than likely prescribed it by their primary care doctor. Maybe not always, but I feel like that's mainly what we see at Victory. And it's a relatively limited workup of their cholesterol levels. But what are the limitations of the standard lipid panel, and why do most doctors rely on it to prescribe statins or other cholesterol lowering medications?
So the traditional lipid panel is limited, but it's in the guidelines, and that's why most people still utilize that as the way that they prescribe therapies to treat risk, because a lot of the risk calculators only use LDL cholesterol or HDL cholesterol metrics. So in a traditional lipid panel, you're just measuring total cholesterol, HDL cholesterol, triglycerides, and a calculated LDL cholesterol often. But I talk about with patients that cholesterol is a waxy compound. It's critical. Without it, you're not alive. You make your cell membranes with it, you make your bile acids, you make your hormones with it. But because it's waxy, it needs something called a lipoprotein to transport it through the blood vessels. So the liver makes those lipoproteins. I use a tennis ball analogy in my office that the cholesterol goes inside the tennis ball and then floats through the arteries. But in the traditional lipid panel, if your total cholesterol is over 300 milligrams per deciliter and your LDL cholesterol is greater than 190 milligrams per deciliter, then very likely you have familial hyperlipidemia, which is a genetic abnormality that significantly increases your cholesterol. But it's the particles that transport them that actually predicts the risk. And this played out in the Framingham Offspring trials and the MESA trials. So you want to actually measure how many particles transport the cholesterol, not just the cholesterol. So that's where APO-B comes in. And Lp(a) is just another APO-B containing particle, but it's more atherogenic and thrombogenic, meaning it's more likely to cause plaque in the arteries. It's more likely to cause the blood to clot. So if you don't test for it, you don't know what exactly you're treating. So if you just use a traditional lipid panel, the LDL cholesterol is actually going to falsely have Lp(a) attached into that value. So some patients you can give statins to and their LDL-C will go down significantly, but some, the LDL-C won't move much, and that's probably because they may have Lp(a), and that's what you're not going to know unless you actually test for Lp(a).
I think this is what happened to my dad, isn't it? My dad's, I don't know if you recall, I feel like my dad's Lp(a) was super high. Do you recall? Can you remember?
I don't remember what his LDL-C was before that, because I think you guys had already gotten him some of the APO-B particles, but I can go back and look at his records to see if that's the case. But that, is one of the things where, I often will see this where, patients, are on certain therapies and their numbers are getting to whatever goals their doctors are prescribing. And then if you do, tests like the Boston Heart Lab, then you realize, oh, this is more of a hyperabsorption issue. Ezetimibe is probably going to work a little bit better for this person. It's not saying statins are always wrong, but you can just find the right tool for the job and get the dose right.
Yeah, so on this Boston Heart panel that we're going to be doing, do you kind of want to break down a little bit more of that panel versus what you see in a traditional panel? And then, I know the next question, the patients are thinking, well, can I just go to my primary care doctor and ask him for that more advanced panel? Maybe explain.
Yeah, the Boston Heart Lab panel, I don't remember everything we decided to put on yours, because I remember we just had dinner, I was checking off the boxes, but I know the basics of what's going to be on it. So I usually kind of chunk it down to 3 buckets. One bucket's going to be the lipoproteins. So this is where you're going to look at the LDL particle count. So how many particles are transporting the cholesterol through your system? There'll also be a number called APO-B or apolipoprotein B. And on the new patients, we had them get checked for Lp(a), which you just need to at least be checked one time in your life. There's a test on the Boston Heart panel called the cholesterol balance test. And that looks at, are you more of a hyperproducer of sterols or more of a hyperabsorber of sterols? Meaning, is the issue primarily in the liver that you're making a lot of cholesterol, or is the issue mainly in the gut that your body keeps recycling a lot of the cholesterol? Because the only way cholesterol leaves the body is through the gut. And in about 20% of the population, people hyper-respond and hyper-absorb that cholesterol from the gut. And so it's color-coded to determine what level you are in each of those categories. And if you're at the top where you're more of a hyperproducer, then this is where statins or bempedoic acid, which is Nexletol, tends to work better. If you're more of a hyperabsorber of sterols, this is where the prescription medication ezetimibe or Zetia was the other name for it.
Yeah, I think that's what my dad's on now.
Right.
Keep going. Sorry, I interrupted.
So that's the kind of the lipoprotein bucket. The second bucket is the bucket that affects oxidative stress and inflammation. So, you're breathing oxygen, you're using that oxygen to combust the carbohydrates and the fats that you're eating to make energy in the mitochondria. But during that process, there's going to be free radicals made. And you can measure how much free radical damage is happening in the body. Also, how much inflammation. You want your immune system to kick on if you have an infection. You just don't want your immune system always turned on because it's more likely to damage the lining of the arteries if that's true. So you can look at labs such as high sensitivity CRP, how much global inflammation is in the body. You can look at PLA2. It's more of a marker of how specifically inflamed the artery lining is. Myeloperoxidase also looks at vascular inflammation. There's oxidized LDL. So are you basically rusting your cholesterol? If the cholesterol is oxidized or modified, it's much more likely to get trapped in your artery lining. So that's the second bucket, is the inflammatory and oxidative stress bucket. And then the third bucket is the pathways that would affect nitric oxide production. So I know you've had Dr. Nathan Bryan on your show. Nitric oxide is critically important for vascular health. Without healthy nitric oxide levels, you're going to have poor vascular outcomes. So nitric oxide helps dilate the arteries. That keeps blood flow normal, blood pressure normal. But nitric oxide prevents lipoproteins from sticking to the artery in the first place. So you can look at labs such as ADMA and SDMA. If those are high, you're likely to have lower nitric oxide. Elevated homocysteine, likely have lower nitric oxide. Elevated uric acid often goes along with insulin resistance. Again, you'll have lower nitric oxide levels. So those are kind of the three big buckets to think about it. Cholesterol is important, but sometimes it gets to be made the boogeyman that cholesterol is high, lower it to zero. Well, you need cholesterol, but you also need healthy arteries. And so there's biochemical testing you could do. That's these Boston Heart Labs. And then I know we'll get into the biophysical. What is the arteries actually doing with the things that are floating through your blood?
Do you feel like more patients or more people know about the APO-B since Peter Attia's book, or do you feel like where are people getting their knowledge around APO-B? Because I do feel like it's becoming a little bit talked about a little bit more. Patients are seeming to be more aware that they should know what their APO-B numbers are.
I would suspect that a lot of it had to do with Dr. Attia's Outlive book, but I'm smiling a little bit because I think it's because I've been talking about it a lot for the past 10 years, so I don't even know where other people are actually hearing it. So, I think I first heard about APO-B back in 2013 from Dr. Mark Houston, who's been a great mentor of mine. So, I've been thinking about this for 10, 11 years. It's not a new topic. It's just that it's now getting people's attention. And, it's the right question. If you want to understand everything cholesterol metabolism, it's going to take many, many years. But if you want to simplify it, how many APO-B particles do you have on a lab test? If you have it greater than the 20th percentile and you have plaque in your arteries, you're probably going to want it lower than that through any means possible, of lifestyle interventions, supplements, or pharmaceutical options.
And I feel like the APO-B is something that you could ask your primary care doctor to be adding onto their panel, right? Do you think that? It's a couple dollars to test that, and that seems like a reasonable ask, and that they're becoming more well-versed in that area.
I would agree with that, yes, because APO-B is available through many labs, and it's maybe $5. It's not a hard test. Now, that cholesterol balance test, right now, only Boston Heart has it. There's a kind of a at-home test called Empower DX that you can do it at home, but honestly, you do the finger stick, you bleed onto a card, you mail it in, they send it to Boston for them to run it. So it's really Boston Heart that's doing it anyway. So that's the one thing where it's useful if people are trying to figure out which medications or lifestyle interventions are they going to respond better to. You can look at the Boston Heart Lab. But if you don't have access to that, start with an APO-B. And if your APO-B is above 70, you may have to ask questions about should it be lower than that.